So welcome everyone to Elder Abuse Prevention Ontario's webinar today on capacity, insights from across the healthcare spectrum. We're pleased to be presented with many panelist speakers today, and we'll be presenting them shortly. But just before we get started, I wanted to go over some of the housekeeping agenda items. Everybody will be muted during the presentation today, and the session is going to be recorded and will be posted on our website within the next day or two. And we are joined with Asl Interpreters for our session today as well. And as I indicated before, if you find the screen smaller, you can drag the screen to the left and you can adjust the screen to your liking. There will be, the speakers, as I indicated, will be visible during the presentation if they're speaking. We will be asking them to turn the cameras off after we get going for the presenters, so we can focus on the presentation. And then when we have our panel discussion, everyone will turn their cameras back on. If you have a specific question that you would like to ask the panel members, we would really encourage you to put that in the question and answer box, and we will respond to those at the end of the session. And if you have just a comment that you would like to make on somebody's presentation, please put that in the chat box. It's really helpful for us to respond to the questions at the end if you put the questions in the question box. I know sometimes we forget, but it's easier for us to sort of look at the themes of things that are being asked if we're able to put them in that question and answer box. And we would just ask your feedback for evaluation at the end of our presentation to give us some ideas of future topics that you'd like to see and any feedback on today's session as well. So before we get started, I would like to provide our land acknowledgement for our webinar today. So we acknowledge that the lands that we live and work on are the traditional territories of many nations and home to many Indigenous peoples. There's a new understanding of our interactions and engagements with this land and its people, and we endeavor to honor them by strengthening our relationships and responsibilities towards them. While there is an important work being done by many nations and allies to ensure the continued thriving of our communities and knowledge systems, we recognize that our knowledge and way of doing things may not be the priority as we work towards a safe, abuse-free Ontario for all seniors. So for those who are just joining us for the first time, Elder Abuse Prevention Ontario has been hosting many sessions throughout the past year because we really want to do education and outreach and training to our community stakeholders, partners, seniors, and caregivers, because we envision a province that is free of abuse for all older adults, where older adults feel safe and respected within our province. We work with many community partners and organizations throughout the province, as well as nationally and internationally, to help streamline and coordinate our activities and work with like-minded organizations to ensure that we're providing the best services and education that we can to you out there in the community. And we also support and work in terms of advocacy to support these initiatives that we're involved in. So just an overview of the presentation today. We're organizing it in a way that we'll have each speaker, our guest panelists, will do a presentation about 5 to 7 minutes on their organization and their role within the healthcare sector. Then we'll have a panel discussion based on a case study that we're going to present to you. And then each person will respond based on some proposed questions that we had just around capacity and consent and issues that will be evolving. And you'll find that the case study that's being presented may reflect something that you have been involved with yourself. So hopefully this will generate some discussion questions and provide further clarification to the work that you're doing in the community. So I'm going to turn it over to my colleague, Mary Sikorsky, who is helping organize this session along with Courtney from CAMH, who's been a great asset in getting this session organized. So I'm going to let Mary introduce all of our keynote speakers and take it from here. Mary?
Wonderful. Thank you, Rayanne. And thank you to our very distinguished panel for helping in today's preparation for this webinar series and panel discussion. So we're going to let each member of our panel introduce themselves, and as Rayanne talked about, speak about their role in what they do in the community, and then they will be speaking to us a bit later on throughout the panel discussion. So we will begin with our first member, which is Dr. Kitamara, who is our geriatric psychiatrist from the esteemed Baycrest Hospital, which has a very special place in my heart. So Dr. Kitamara, please take it away.
Great, thanks very much, Marianne and Rayanne, and thanks for everybody for attending and for having me. And, I look forward to today, and I look forward to hearing from the other presenters too. And I got connected with this program today because in addition to my work as a geriatric psychiatrist at Baycrest, I also work with the Peel Dufferin Area Canadian Mental Health Association as a consultant. So Courtney is connected there. So that's how she was kind enough to bring me in. So I'll just say a bit about what I do. So I'm a geriatric psychiatrist, which means I trained first as a general psychiatrist. And of course, that means I'm a physician. So I did medical school and then residency training in psychiatry. And then I did a fellowship after that in geriatric psychiatry, which is a 2-year additional training program. And it's a training program available throughout the country, but still a relatively small field that we work in geriatric psychiatry. And it's like a Royal College of Physicians sort of certified designation as well. And I work primarily at Baycrest, which you might have heard of. It's a geriatric facility in Toronto, but we do have partnerships and do some outreach work like I do with the Peel Dufferin CMHA. Also, as I'm sure everybody who's participating or who works in the geriatrics area, we do a lot of work in teams, right? So I work with the Canadian Mental Health Association, and we're a team in that sense. And a lot of my work, pretty much all of my work through Baycrest is with a multidisciplinary team, which is very valuable. We'll talk about that. And I was going to say next a little bit more about what's unique about geriatric psychiatry, and I see Nikki had a question. So it's in addition to diagnosing and treating mental health conditions, symptoms of all forms, I guess in geriatric psychiatry, a few things that are unique are, of course, we deal a lot with people with cognitive disorders, ranging from cognitive symptoms to dementia of all degrees, which, you know, our fancy term now is a major neurocognitive disorder. Also in geriatric psychiatry, of course, that means working with people who might be more medically unwell or frail. So we kind of also have some expertise at looking at the kind of interface of physical illness and mental and cognitive health problems. And we also, similar to how I work in a multidisciplinary team, we often also think of the patient and their family as a version of a team as well, right? So we work a lot with, family units. So that there's kind of this idea of the identified patient, and then they might have spouses or other family members that are important factors in their care. And also in geriatric psychiatry, the issue of capacity does come up quite a bit. I'll just say in brief, probably 90% of what I do is sort of general psychiatric care, diagnosis, treatment, support, and planning. And I would say less than 10% of time we are asked to kind of weigh in on issues around capacity, sometimes with this sweeping statement of is X patient capable, right? That's a common question. Is this person capable? And I think we'll break that down today to that there really isn't this global idea of capable or incapable. And capacity is sort of, I think some of the fancy term is it's decision specific, and it's also time specific. And also a small minority of my cases are regarding actual or suspected abuse, or maybe otherwise situations that are risky and may not be kind of frank abuse now, but because of various dynamics or caregiver stress and burnout, there might be a risk of abuse and neglect. I'm not sure how much more, do we want to, can I go a little bit more, or do we want to just keep a brief intro for now, Mary and Rihanna, and then come back to a bit more about kind of what we do and how we do it? I wasn't sure of the timing.
No, please feel free if you want to go a few more moments, by all means.
All right, I'll go a few more minutes. So I guess what I'll say around more about capacity. So as a geriatric psychiatrist, and I guess in general a physician, there's, I would say, a sort of a narrow number of questions regarding capacity that we're tasked and trained to be the formal assessors of. And primarily it relates to medical treatment decisions. So certainly for issues around psychiatric needs and treatments, I would be the one proposing those treatments. So I would be the one assessing someone's capacity. And we'll hear more today about the idea of kind of the two-part test of someone has to understand the relevant information and then appreciate the consequences of their decisions or lack thereof. And then sometimes we get, then similarly around decisions around other treatments. So if a patient that I'm seeing maybe needs surgery or needs invasive heart investigation, it would be the physician who is treating those conditions who would be the final say and the formal decision around capacity. Also, in the way for all other areas of capacity, because sometimes we do get asked to weigh in on issues about long-term care decision making, or financial capacity, or creating wills or powers of attorney. While we may not be the kind of the formal decider, often we do have a role in terms of with the proper request, opining whether somebody has a psychiatric or cognitive or medical condition that might influence their decision-making capacity. And then also, are those conditions modifiable, right? Certain conditions like dementias, of course, are not reversible, but others, dementia, depression, psychosis, and delirium might be, and there might be important treatments that we can help with. And also sometimes I get, as a psychiatrist, and I think all physicians are presented with cases of possible abuse. I guess what I would just say for start is that it's important, of course, to any question about abuse to take it very seriously, and that it's appropriately investigated and supported, and whatever interventions are appropriate that we'll talk about. But also it is important to remember that people with dementias, can be prone to false beliefs and false memories, and it shouldn't be the assumption, but sometimes related to dementias, for example, people and timelines could sometimes get blurred, and in psychosis there could actually be frank delusional thoughts, sometimes related to persecution and abuse that may or may not be occurring. And trying to gather information and support and follow people over time can be valuable, and supporting people through their experiences of actual or perceived abuse, regardless of where the actual facts lead us. Sometimes it's not always clear, but knowing that somebody who has the experience of abuse needs all of the appropriate supports and treatments, including around mental health effects. Okay, maybe I'll stop there.
Wonderful. Thank you so much, Dr. Kitamara, and we look forward to hearing from you a little bit later on in our panel discussion. And already I can see a lot of questions in our Q&A box for you, so we will address those. Next, I have the pleasure of introducing from our Central West Home Care, from our LHIN, Candice Kalapaka. Candice has been with the Central West Home Care as a home care coordinator since 2012, and she is now the team manager at the Dufferin-Caledon Headwaters location. She has many years of experience in navigating patients and having conversations about consent and capacity. So I look forward to now introducing Candice and having her speak a little bit more to us about her role. Thank you.
Thank you. Yes, I've been with Central West LHIN Home Care, started out as frontline for back in 2012. So it's been a number of years, and now the manager for the team in the Dufferin-Caledon region and the Headwaters Hospital team. And we do work closely with our partners such as Dr. Kitamara and CMHA, Peel Dufferin. to support patients and families on their journey and looking at long-term care placement. We play a major role in that. And my training, my background is I'm an occupational therapist. I completed my education at U of T. And so I did do some occupational therapy in the community prior to joining Central Wesleyan. Okay, so sorry, I didn't know if you wanted to go through the introductions of the others, but I can go through my slide deck now if you want.
Yes, please.
Okay, sorry. So yeah, a big thank you, of course, for including us in today's panel. Consent capacity is, of course, a significant hot topic for us. We have a very unique role and responsibility to evaluate a person's capability to provide consent to admissions to long-term care. And similar to what Dr. Kitamara was touching on in his role of, you often get asked that question around, is this person capable? And it's like, wanting that overarching, they're incapable or they're capable for everything. And that's not actually how it does work. So care coordinators, of course, are regulated healthcare professionals. They may be a nurse, a physio, OT, social worker. And our responsibilities are around assessing the needs of patients to create their care plan, which could be services from us. It could be linking them to other resources. And to do that, we have to collaborate with a number of professionals that are formal or informal caregivers as well as our primary care, our hospital partners. The list actually is quite endless of the people that we work with. And then is working with that patient and family unit and a caregiver, because it may not necessarily be an immediate family member, in order to help to navigate them through the system and set up a plan that works for them. And that requires, of course, ongoing monitoring of their progress and how they're doing, and updating and revising that plan. And as I mentioned, it's a big part of what we do is assessing and determining eligibility for admissions into long-term care. So for those of you that have been participating in the speaker series, you would know from past speakers events about, they've shared a lot of information around the Substitute Decisions Act and the Healthcare Consent Act and PHIPAA and privacy. So we won't be getting into like big details onto that today, but we all have a role in our system as the care coordinator, and we are considered under the Healthcare Consent Act an evaluator. And every person is presumed to be capable. That's important to understand until there is reasonable grounds or evidence to suggest otherwise. So, and when there is that evidence, it's our role, we're tasked with the responsibility of completing an assessment to determine whether the patient has the capacity to make decisions regarding the admission to long-term care. Next slide, please. So consent capacity, it is a legal matter, even though we're all healthcare professionals. As I mentioned before, we are an evaluator under the Healthcare Consent Act, and our focus is like, does the person have the capacity to make the decision regarding admission to long-term care? That is very critical. We don't have the ability to determine if they have the ability to make a decision to go into a retirement home or to make the treatment decisions. That's the treatment provider, and the panelists will, of course, go through each of our individual roles in the system when it comes to consent and capacity. So it's very specific to admissions to long-term care. Next slide, please. So as Dr. Kitamara mentioned, it's a two-part test for all of us, actually. It's just the information that you're considering because it's specific to the decision you're evaluating about. So for us, that two-part test is, does the patient have the ability to understand the information that is relevant, and I highlight relevant, to a decision regarding admission to a long-term care home? And then the second part is, does that patient have the ability to appreciate the foreseeable consequences of the decision or the lack thereof regarding admission into a long-term care home? So first, there is there's no formal actual multiple choice test or standard set of questions, because each patient and their situation is very unique. So the intent is to assess their understanding and appreciation of the information, as I said, that is relevant and reasonably applicable to that person and their situation. So the assessment, we have to be able to gather the information that's going to enable the care coordinator to be able to determine if the patient has the ability to understand information that's relevant to a decision regarding the admission and has the ability to appreciate those foreseeable consequences. So the things that we are considering are about the cognitive ability to process, grasp, and retain the information that's going to be relevant, and also to make sure that we are doing our due diligence to provide patients with information that they can reasonably expect to be provided, to be informed. That's the health literacy piece is important, and teaching and helping them to understand what their options are. Because asking someone, what do you know about this, if they've never ever had an opportunity to be educated on it, then it's very unfair to assume that they should, provide reasonable answers. So does the person understand what a long-term care home is after we provided this education and the type of assistance and care that's available in the home? Does the person recognize his or her medical conditions or medical care needs? And does the person have a medical diagnosis that could impact his or her ability to understand the relevant information? So it's not a memory test. That's important to also explain. The second part of that, about looking at what they can appreciate, is the patient's reasoning process and ability to apply the relevant information to their circumstances to weigh the foreseeable risks and benefits. Can they recognize those risks and how they impact them directly? Or can they recognize how admission could benefit them? And can they identify an alternative plan or living arrangement for their care? So next slide, please. So this infographic is just to demonstrate that a patient's journey in our healthcare system is not linear. There's many factors that contribute to their experience and their understanding and appreciation of relevant information and potential foreseeable consequences. And we want to gather the important facts about potential and confirmed risks. We want to identify the potential external contributing factors that could be impacting that person's capacity, so that underlying medical issue, whether it's acute or chronic, or medications, their lifestyle, their behavior, their food, security, nutrition, all these things make up the person as a whole and contribute to their situation. Are there medical investigations in progress? Knowledge and awareness of when a patient's performance is optimal is also important for us, so that when we are doing these assessments, we make sure that we're doing them and give the patient the opportunity and the dignity to be able to perform at their best. We're not trying to actually assess them when it's the time of day when they would perform at their worst. So looking at things like setting them up in the environment for success for hearing and visual impairments, taking that into consideration, as well as communication, language. We frequently use interpreting services as well. And we gather all this collateral, but it's important that we recognize that there's an importance of we have to avoid bias. And going back to what I said before, is presuming that the patient is capable until the assessment is complete, even though there's some evidence to suggest that someone's having difficulty now making decisions. Next slide, please. So what to expect during an assessment? Of course, there's an introductions and review of the purpose of the assessment and potential consequences, getting that informed consent. We have guiding questions. We don't have a script. It's our obligation is to make sure we probe and verify the responses. It's not just a simple yes or no, because we want to make sure that we're asking questions in a way that a person can understand them and have reasonable opportunity to explain themselves. If upon conclusion the patient is found incapable, they're of course informed of that and notified of their right to appeal to the Consent Capacity Board, and we would have the obligation to assist the patient with filing that appeal if that's what they wish to do. It's also important to recognize that persons may be incapable of making one decision. So for example, long-term care admission, but they're also able to make other decisions in other domains of care and treatment. Also, the important thing to realize is it's moment in time assessment. So we may have a patient in a situation whereby, due to the urgency, we need to assess and establish if they're capable or not of making a decision regarding admission. However, with appropriate care and time, their condition may actually improve and they may regain their ability to make decisions on their own. And that's okay. This is not meant to be punitive. It's not one and done. We have to respect the rights of the individual, and we would reassess and go from there. The assessment process is objective. So it's about what would and what decision would be in the patient's best interest is actually not relevant to us. That's the decision maker that has to take that into consideration. So ultimately, patients, they get the right to make poor choices. Our focus is on the person's mental capacity, not their wisdom. And we have an obligation to respect choices and the right to live at risk if they understand the risks and appreciate the reasonably foreseeable consequences. Next slide. So in the event, what happens if a person is found incapable? Of course, we defer to the hierarchy that's set out in the Healthcare Consent Act that outlines, you start with the guardian, if there's a POA, if there's a representative appointed by the CCB, the Consent Capacity Board, they have a spouse or partner, you go through the list to find that SDM that will then fulfill the following, which is around being capable with respect to decisions regarding admission and at least 16 years of age, of course, unless they are the incapable person's parent. And of course, there can't be any court order or separation agreement that would prevent access to the person that is incapable of giving or refusing consent. And then they have to be available and willing. And those, the first three items are usually not of an issue, but the availability and willingness is a big piece of what we do around making sure we are educating the substitute decision makers around their roles and responsibilities as well. Next slide, please. So, and what is the expectations for that SDM? So just highlighting this, I think it's also important, is that the Healthcare Consent Act is actually quite prescriptive. So if the patient has an expressed wish regarding admission to long-term care that is applicable to their circumstances while they were capable, and the SDM has a responsibility, of course, to consider that prior known wish when making decisions about what's in their best interest. And they have to comply with that and act in their best interest. So it's the wish must be expressed while the person was capable. That's important to note. Sometimes they're known because people have highlighted in a power of attorney document or another written document, or they communicated it orally. But those wishes also have to be applicable to the person's current circumstances. So sometimes we express something 10 years ago, and then all of a sudden now the situation has changed. So general preference is for a person to remain in their home for as long as possible. But the thing is, people's conditions will deteriorate over time. And so now you have to consider their current circumstances. They are not, prior known wishes are not to be applied just mechanically or literally without regard to the relevant changes. Even though they're expressed in a categorical or absolute terms, they must be interpreted in light of the circumstances prevailing at the time the wish was expressed. And this is in case law, Conway versus Jack. So wish must be clear, precise, and made in contemplation of any actual changes in circumstances. So, and lastly, if the SDM is suspected to be incapable, we we would ask them similar questions that we would ask a patient to determine if they're actually able to understand and appreciate the relevant information to be able to make the decision on behalf of the patient. And the SDM cannot just assign the authority to someone else. And for us, unless it's unreasonable to do so, we are obligated to rely that the individual's representation that they are the appropriate SDM, like we have to take that at face value, unless there's some other reason to suggest not to. And when substitute decision makers have equally ranked decision-making authority, but they actually may disagree on the decision, ultimately we try to support them around considering all the facts and the evidence to make the decision. And if they can't, we would be turning to the Office of the Public Guardian and Trustee. So anyhow.
Wonderful. Thank you so much, Candice. That was a very in-depth overview from our partners and friends over at the Local Health Network. Thank you so much. Next, I'd like to introduce to you Shauna. Some of you may recognize her from a previous webinar that received quite a huge outreach a few weeks ago from a presentation that she had done for us. So thank you and welcome back to joining us today on our distinguished panel. So a quick overview, Shauna has been an occupational therapist for over 25 years. You'd never know that by looking at her. And much of her career had been spent with the Community Care Access Center, the CCAC, and Veterans Affairs. Her time was spent visiting with seniors and adults with disabilities who were living in their own homes. Many of her years of experience come from working with adults with memory or cognitive impairment, as well as their families and caregivers. For the past 8 years, Shauna has built an exceptional reputation as an experienced and fair advocate for people with cognitive impairments and those who are vulnerable to elder abuse. She is also a valuable member of the Kawartha Lakes Haliburton Elder Abuse Prevention Network for several years and has been a member of both the GAIN Advisory Team and the Haliburton Services Network and City of Kawartha Lakes Situation Table. Thank you so much. Welcome, Shauna.
Thank you very much for having me. I appreciate that introduction. In addition to being an occupational therapist, I am what's called a designated capacity assessor. So you can imagine it's quite a mouthful when you walk into someone's room and say that you're Shauna McEachran, an occupational therapist and designated capacity assessor. So my job as a designated capacity assessor is to determine whether someone is mentally capable or incapable of making a decision. And so unlike my colleagues who deal mostly with the Healthcare Consent Act, a lot of what I do is prescribed in the Substitute Decisions Act. So the Substitute Decisions Act outlines the same definition, whether someone can understand the facts of the situation and whether someone can appreciate the pros and cons, appreciate the risks, the benefits, and the potential consequences of their decision. And so under the Substitute Decisions Act, we deal with two broad categories. One is decisions around property, which actually means finances. So property decisions, money decision, financial decisions is one category. The other category that we deal a lot with is the broad category of personal care decisions. Now, personal care decisions is an umbrella term that has 6 categories under it. So it has shelter, safety, health, clothing, hygiene, and nutrition. So those 6 categories together make up the personal care realm. So the Substitute Decisions Act has given capacity assessors, designated capacity assessors, some specific and exclusive authorities as far as making decisions. So next slide, please. The important thing when we have designated capacity assessors, they could be doctors, they could be nurses, they can be psychologists, social workers, or occupational therapists. So any of these professionals can become a designated capacity assessor. In order to become one, we have to have completed a training program through the Ministry of the Attorney General. So this again is a legal program. It's not a medical. We have to have both. We have to have the medical and the legal. And we have to be a member of our respective college. So in order to be a capacity assessor, I still have to be an occupational therapist. I have to bring both sets of skills with me to the table. Next slide, please. So there was a little bit of alluding to the difference between a capacity assessment and a capacity evaluation. So as I said, I do a capacity assessment as a designated capacity assessor, typically. So this is a legal assessment. It's a legal assessment under the Substitute Decisions Act, and it has the potential to change a person's rights, to actually restrict or otherwise change a person's legal right to make their decisions from this point in time moving forward. A capacity evaluation, in contrast, is completed by an evaluator. So an evaluator could be any of the professional regulated health professionals, but typically it's done under the Healthcare Consent Act. So it could be a decision around treatment, a decision around long-term care, lots of other different decisions, but it tends to be more of a point in time. It's very specific to these issues at hand right now, and it tends to be an evaluation of a person's ability right now. The capacity assessment tends to be a bit more longer term in most cases. Next slide, please. So when do I actually need a legal capacity assessment? When do I need a substitute or a substitute? Nope, wrong one. When do I need a designated capacity assessor? So there are some cases where a designated capacity assessor is called upon to assess for the office of the public guardian and trustee to become the guardian of property. So guardian means we've taken away that person's right to make their own decisions about property, which is finances. And we will do that if there's no power of attorney, if there's no other alternatives, if there's nobody who can actually manage the money for an allegedly incapable person, then the safety net is the office of the public guardian and trustee becomes their guardian of property. And so a designated capacity assessor is the way for the community-based patients to access that system. So under the Substitute Decisions Act, we do what's called a Section 16 assessment. Now, there are other mechanisms through the mental health programs. I'm not going to get into those. Those are called a Section 15 assessment. And that's when somebody's an inpatient in a psychiatric facility or in a hospital for treatment of a psychiatric condition. But in the community, we're dealing with people outside for the most part. So we're also looking at legal assessments potentially if a family or a support person is looking to apply to the court to ask the judge for permission to make decisions on behalf of someone. So a family member or other support person can ask the judge to become the guardian of property or for the guardian of person. So, but it has to be decided by a judge. A legal assessment might also be required if the power of attorney document actually has a clause in it, a triggering clause that says this only comes into effect if or when I am found to be incapable of making this decision. So that triggering clause requires a legal assessment on the appropriate legal forms to say this situation has been met and the person has been assessed by a designated capacity assessor as incapable of making their own decisions. And therefore, that triggers the power of attorney's authority to now act on their behalf. So next slide, some examples of formal capacity evaluations. So these aren't assessments, these are evaluations. So often we get requests as a designated capacity assessor. I'm often asked to comment on someone's capacity to grant or revoke a power of attorney. So it's most often lawyers who are calling and asking for that type of assessment. Similarly, the capacity to write a will. A lawyer may want to do their due diligence, may not feel comfortable in determining capacity, and so may ask for an independent third-party opinion. Banks, often doing their due diligence, sometimes banks or insurance companies will want some kind of assurance that this client is in fact incapable and that they're aware and wanting their power of attorney to work. So the more complicated a person's affairs are at the bank, the more likely the bank is to question the authority of an attorney under a power of attorney. And sometimes we get called in to do professional opinions about making personal care decisions. So remember that personal care includes healthcare and shelter and safety. Those are the three big ones that I would get involved in. But it tends to be an independent third-party opinion. So mostly where people are arguing, mostly if the team can't quite come to an agreement, or if the family and the team can't agree on whether a person's capable, they may call in. It's by no means necessary, but sometimes it's helpful as due diligence. So those are some examples of formal capacity evaluations. The other types of capacity evaluations that are done by all health professionals, we've already touched on with my colleagues, consent to treatment, consent to share information falls under that as well. Capacity to consent for support services such as personal support workers and nursing, and capacity consent for long-term care. So those are evaluations under the acts. So those are my roles.
Excellent. Thank you so much. Again, a wonderful overview, very in-depth on capacity assessments and evaluations. If I can just ask everyone, please, I know there's such a flurry of questions people are asking. If you could please put them in our Q&A box. This way we've just got everything organized when we're able to address all the questions at the end of the panel discussion and case study versus having them in the chat box. And thank you all. There's excellent questions and participation. So I love to see everybody so engaged. Last but not least, before we begin our case study, is to introduce a good friend and colleague, Courtney Boucher from the Seniors at Risk Coordinator. She is part of the team at the Canadian Mental Health Association of Peel Dufferin. She has been working there since 2013. Courtney started in the position of a seniors intensive case manager and then moved into the role of a seniors at risk systems coordinator position in 2018. In this wonderful role, she supports individuals who are at risk or currently experiencing abuse, as well as those who are vulnerable and are experiencing mental health concerns or self-neglect. Courtney works as part of a transdisciplinary team and has experience working with individuals whose capacity is in question. She supports linkages and referrals to appropriate assessors and provides educations to individuals, caretakers, and community partners. Thank you and welcome, Courtney.
Thank you, Mary. And thank you everyone for attending today. I am kind of the oddball here because I actually don't do any assessments on capacity or evaluations, but my role is those linkages. So as mentioned before, kind of in collaboration with Dr. Kitamara, as well as Candace Kalpaka and Mary and Rayanne, is kind of how we came to coordinate this presentation. And we're so grateful that Shauna was able to participate as well. So my role in the community is often a first line of engagement. One of the ways it can be first line of engagement. Again, it would be supporting individuals who are at risk of or currently experiencing abuse, self-neglect, mental health or cognitive decline. I often get calls from neighbors, concerned community partners, just not sure where an individual fits. So I go out and do those initial assessments, speak with individuals. Again, as Dr. Kitamara expressed that we often work with the family network, I do that as well. So I speak with the family, I speak with anyone who might be deemed close to that individual to figure out what's going on in the next steps, and then make the linkages, whether that be to Dr. Kitamara for further assessment, whether it is to Candace and her team at the LIN for further supports, and or even capacity assessor if we are concerned about finances or property. So again, those linkages are key part of my role. I also provide education and training to community partners, agencies, and the general public. I do a lot of discussion on rights and responsibilities of powers of attorney, and also just work with individuals and their family networks through the process of that. So I'll keep my introduction brief just so we can get on with the case study. I will mention for my particular role, I am specific to Dufferin County. I am aware though that there are other seniors at risk coordinators in other communities. So I do encourage you to reach out to GP offices, local Alzheimer's societies, local LINs, just to inquire who that individual might be in your area so that you can have that, that linkage. So we're going to move on to the case study. So I'm going to read the story of Mr. Smith, and then we're going to have the discussion from our esteemed panel just to talk about how they would engage and what level of supports they would provide. Mr. and Mrs. Smith were first referred to the Community Seniors at Risk Systems Coordination Program by a neighbor who shared concerns about an adult son possibly financially abusing the couple. It was reported that this son was unemployed and living rent-free, however, had recently purchased a new vehicle. During conversations with the couple, the SARS, which is usually what I'm referred as, became concerned about capacity and decision-making for both individuals. Mr. Smith showed signs of cognitive decline with poor short-term recall. He appeared to be spending large sum of money, which Mrs. Smith indicated they did not have the financial means for, such as the purchase of a new vehicle for their son. Mrs. Smith had expressed anger and resentment towards her husband, stating that he was spending their nest egg and was becoming increasingly verbally and physically aggressive towards him. Mrs. Smith shared that her husband's cognition had changed over the past couple of years, and with this decline, she had noticed the increase in his spending habits. No diagnosis has been confirmed at this time. Mrs. Smith has POA for finances, power of attorney, for Mr. Smith. However, she expressed fears about going to the bank to resume control, as Mr. Smith has historically managed his own finances. She reports that they have different accounts along with a joint account, and that she would need more verification that he was no longer capable before she was comfortable taking over. Cognitive and mental health assessments were conducted on the couple. The first used was the Montreal Cognitive Assessment, which is a screening instrument used to facilitate the assessment of mild cognitive impairment. The second assessment used was the Geriatric Depression Scale. This is a screening tool specifically designed for older adults to facilitate assessment of depression. To note, it does not assess for suicidality. Neither tool provides a diagnosis, however, are used as part of an overall assessment from a healthcare professional like Dr. Kitamara or a family physician. Mr. Smith scored a 13 out of 30 on the MOCA and a 5 out of 10 on the GDS. Mrs. Smith scored a 24 out of 30 on the MOCA, as well as an 11 out of 15 on the GDS. PSW supports were placed in the home 2 times a week, as Mr. Smith required further assistance with bathing. The couple, however, have been resistant to the presence. The Seniors at Risk coordinator, while completing assessments, noticed changes in the dynamics in the home and that they continue to escalate, with Mr. and Mrs. Smith displaying verbal and physical aggression towards one another. Mrs. Smith expressed concerns that she was done caring for her husband and stated that she no longer wished to live with him. She further stated that she did not want to leave the home. Mr. Smith also expressed that he will not leave his home. Mr. and Mrs. Smith declined other supports that were recommended, such as increased personal support workers, Meals on Wheels, and the Alzheimer's Society. Retirement home and long-term care had been discussed with both individuals. However, neither were willing to make the decisions necessary to move forward. The Seniors at Risk expressed concerns that neither Mr. or Mrs. Smith were making sound decisions and were potentially putting themselves at further risk due to the changes in the home dynamic. Mrs. Smith indicated that their adult son, who does reside with them, has talked Mr. Smith into purchasing a vehicle for him. Adult son has expressed feeling that everything is fine and that he does not believe his father is experiencing any cognitive decline. He has voiced frustrations with service providers' involvement and has been creating roadblocks as a result, such as influencing his parents to decline supports. Adult son is identified as an alternative POA in the event that Mrs. Smith is unable to make decisions. Risk factors have been highlighted that there is potential financial and housing gain for the son if his parents remain in the home. The couple reports having other children who were not presently involved. They are estranged from their daughter due to addiction and substance abuse, and shared that they had a son who resided in another province whom they had not seen in years. No other supports were indicated.
Excellent. Thank you, Courtney. Wonderful. And before we just begin our panelists' response, we're just going to just let everyone know, as part of the webinar, it was looking at, you may have seen the puzzle pieces in some of the slides. And what this refers to, of course, is it takes a village, it takes a team. So each one of our members of the panel are in one way or another involved with putting together all the pieces of the puzzle, so to speak, in helping and working with this family. So that is just sort of an indication of what that meant. And Courtney, maybe you could just quickly, just before we start, let everybody know, with those scores, what do those actually translate to and what do they actually mean?
So what I can say is that I'm not an authority to determine what the scores are. I can say, for an example, just based on the literature in my training, that I can say that there's an indication of an impairment. However, it would be Dr. Kitamara, a family physician or whatnot, who would actually be the one that would do that final assessment and determination as to what the scores mean.
Excellent, thank you. And if our panel, feel free, if you'd like to turn your cameras back on, and maybe if Dr. Kitamara would be able to give us a little more in-depth overview about the scores and their meaning for a lot of our guests who are on the webinar today, to help some clarity, please.
Good, thank you. And I think Courtney said a couple of important things already, that these are scales and they're tools that are used as part of an assessment. But they don't make a diagnosis, right? So, you know, when we as physicians make diagnoses, they're, I mean, in all of the conditions that we've been talking about, so cognitive disorders, or if there's some question about mood disorders, for example, these are sort of clinical diagnoses and basically syndromes where we take a history, and if someone has most of the features, and the associated distress or functional impairment needed, then that's what makes a diagnosis. So, but a part of the assessment, for example, if we're going to diagnose, or we're considering a cognitive disorder, would be cognitive testing. And that's a part that needs to be there. So, for example, a cognitive disorder would require some impairments, some objective impairments on testing. I'll say in a moment what the MOCA, sort of when that's used. And what defines a dementia, for example, is when somebody has cognitive impairment plus accompanying functional impairment. So that means they have some loss of, you've heard these terms, the ADLs, the activities of daily living, and those are divided into what we call instrumental or basic. So they at least have some impairment in the instrumental ADLs. So the instrumental ADLs are things like driving, managing finances, cooking, and shopping. And a MOCA is a more sensitive tool. So if there's some questions about somebody who might have a mild dementia, or even kind of the pre-dementia state that you probably heard of called mild cognitive impairment, which is really geared for, somebody might do well, for example, on the MMSE, the mini mental state examination. They might score in that normal range, but it might be picked up on the MOCA. So it's a good tool to use when somebody doesn't clearly have a dementia or been diagnosed. And the GDS is a screening tool for depression. So again, to diagnose depression, you need to have at least 5 depressive symptoms, 5 out of 9 for 2 weeks. And the GDS walks through basically, you know, those DSM symptoms. So, and 5 or more is a positive screen. So Mr. would be borderline here, and then Mrs. would be a screen positive. Thanks.
Excellent, thank you. And now if, since we've still got you up, Dr. Kitamara, if maybe you could speak to us about now, what are the roles and engagement that you would be able to provide support for Mr. and Mrs. Smith?
Yeah, so I guess, and one of the challenges we often encounter is kind of the, or implied here that the patient is Mr. Smith, and we're doing kind of a fulsome assessment of him and assessing him for any cognitive disorders or any other conditions. But there's some hint that's been alluded to that maybe the wife may have some health relevant health or mental health problems herself, for example, depression, right? And that's quite common, as was alluded to as well, depression in caregivers. And the closer you are and the more you're involved, sort of puts you at a higher risk of depression. And she may ultimately end up both working with her, but she may actually end up needing a fulsome assessment herself, and she may need some treatments herself. So the diagnostic, assessment is the first step, and we try to do that by getting information from multiple parties as much as is possible. So it sounds like here, at least there's a good chance there'll be some helpful information from family members and maybe other community partners that are involved. And then also thinking broadly, so as we're thinking in the area of diagnoses, right? I mentioned, in the story, we've heard a bit about some cognitive or mood changes in one or both of them. What we don't quite know yet, and we might want to dig further, are there other contributing health issues? Are there serious medical problems that might be contributing to someone have an untreated thyroid condition, for example, which can relate to brain health and mood problems, or other addictions, right? In this case, there's at least some family history of addictions, right? And could one or more of the parents. Also, when we hear the story of Mr. Spending more, right, and spending money they don't have, it could be related to a few things. It could be related to pressure and a risk of abuse. Could be related, combined with a cognitive disorder. Also would be helpful to think, could he have a bipolar disorder, right? Could it be like a manic state where somebody is spending more money? And I think, the treatments flow from the diagnosis, and sometimes there's a role for medications. You might know even in dementia, there are some medications for most types of dementias that can slow down the decline, but not necessarily reverse or stop the decline. And certainly mood disorders, for example, or addictions, they can be quite well treated. I'm just trying to think anything else right now for me. That's all that there might be other thoughts or if other questions sort of arise. But,
Of course. Perfect. Thank you so much. Candace, would you be able to help and respond in your role in assisting with the family as well now?
Courtney did a great job of mashing, I think, every possible issue together on this case. I don't even know if we have enough time to unpack it all, but typically we would be, of course, alerted when there's identified concerns, when Courtney's gone in and the screening tools flag some changes. And to Dr. Kitamara's point, it's that first, it's trying to rule out the underlying causes. For us, we want to know, like, is this a new issue? Is this a chronic issue? Is it something that can be reversed? It's not as simple as just like, okay, they're making bad decisions, go in, do the capacity assessment, and you're incapable and done, move on, and we're moving you into long-term care. I think that's important to put that out there, is that we would then link this patient and family with things like an occupational therapist assessment to support further for Dr. Kitamara and for Courtney's screening tools to do more in-depth kind of testing, whether it be like the environmental piece, the cognitive piece. And then it's working with, of course, we would work with the primary care provider as well, gathering that information and collateral, the family, in instituting some supports in the home. It's gathering that information from them, whether it be that they're eligible for PSW, or maybe there's other resources that are going in to try to gather the information, the facts. It's very important to gather facts and evidence versus, like, there's a lot of allegation and there's a lot of assumption, and it's very easy to kind of go down the rabbit hole versus are you understanding, appreciating these risks or not? So that's like an important part for us is, and having conversations as well with everyone, that whole collaborative meeting with the family and the team to try to, you know, discuss what is the concerns or the issues and why, and providing education to make sure that people understand why they're a concern and to see what can be actually adopted and implemented before just kind of going automatically to, oh, this is, you're incapable. Presumably knowing this type of case, you know, often the going through all the steps in the process, yes, oftentimes the person might be found incapable, and then it's trying to work around helping people to make those decisions that they're informed. That informed is so critical to what we do as well. So, and we engage like things like social worker as well, like especially if there's like related to things like finances and stuff like that. Again, we work very, very closely with Courtney, hand in hand, I would say. So yeah, that's some of the things I had thought about when I was looking through this case, because we're trying to mitigate risk as well, because even though in that moment in time you may assess and find a person incapable, that next step of admission, that takes time. So you still got to get there. And so you still got to put a plan in place in the interim. And ultimately, our obligation is, quite frankly, with assessing eligibility for long-term care, it's around ruling out that there's nothing else like a reasonable plan of home care services and community services and supports that could help support this person. And we're trying to find out about prior known wishes. Are they known? Are they not known? And you know, exhausting all of that stuff. And that's where you might be engaging, even though the family that are out of the picture, they might actually have some of that information too, if there's permissions given, of course, to include them as well. And they might be willing to be involved. So you never know. But yeah. Courtney, do I have it all?
No, I
Thank
think
you.
it was good.
It was excellent. Thank you. And you're right, Courtney did give us a lot to unpack here and speak about. Shauna, will hand it over to you for your thoughts and comments.
Okay, so my piece of the puzzle is going to be sort of around that financial mismanagement question. I will just sort of reflect back that my stage would be much later in the interaction. I would certainly be wanting to see this person when the treatment options, the ability to manage him have already been exhausted. So everything that home care could do, everything that geriatric psychiatry could do. And if we've still got problems, the community OT visits, we've still got problems if there's still evidence that this man is making impaired financial decisions, then I might be called to look at it. Because remember, my job is a permanent solution, and it's a last resort. We don't take somebody's rights away unless there are no other options to manage that. And so I want to assess that person, to assess Mr. Smith when he's at his best, when he's as stable as he can be. And part of my my evaluation is going to be looking at that. What attempts have been made to educate him? Have people talked to him about the concerns around his spending? Have people talked to him about the budget? Have people been transparent with him about these are the concerns that people have? Because it's not fair to just say he doesn't get it if nobody's actually told him what the problem was. Okay, so a big part of my assessment would be, what has CCAC told him? What did the OT tell him? What did Dr. Kitamara tell him? What did everybody tell him? And to see, did he remember any of that? Did he retain that information? Was he able to act on it? So I'm going to be looking at that process of reasoning, of being able to work through, but I'm not a crisis provider. I don't deal with the crisis. I sort of deal with okay, we've exhausted all of our opportunities. We've exhausted our things that we can do. He's still making poor financial decisions. He's still at risk of losing money because he's mismanaging. Now we have to do something more dramatic. So we'd be looking at then what are the next steps from there?
Excellent. Thank you so much. And Courtney, if you can bring it together for us and now in how you're involved, and maybe even speak to us how you first get involved when this is brought to you and take us through. Thank you so much.
Yeah, so in a situation with Mr. and Mrs. Smith, as an example, the way that I got involved in this case scenario was through a neighbor making a call. And that actually is something that does often happen. I would get a phone call from a concerned community member, has just seen somebody in the community, whether it's a neighbor, also family members. I've received calls from family members concerned about other family members that are potentially abusing an individual or placing them at further risk. So then I would get involved. In this case, again, it's kind of like those initial tools and screening tools that I would partake. I could coordinate and facilitate those referrals to Dr. Kitamara as well as the LIN. Again, those conversations that Shauna was talking about is, have we looked at all of those tick boxes? Have we looked at those conversations about his finances? Does he understand the risk factors? So that would be some of the stuff that I would have some engagement and conversation about is what is your understanding first of the scenario? What are your concerns? I would do that with the whole family unit to get a more further assessment as to what each individual's concerns are, if they do differ from others. And like I said, is kind of putting those puzzle pieces together, where my role is a lot of those linkages and referrals and bringing everybody in to that interdisciplinary team and working collaboratively as a community. Like Candace said, we do often work well hand in hand. And even though we're different organizations, I think we complement each other very well because we do have different lenses, but we also have a common goal, which is to support that individual. So I think that's kind of like a very brief, abbreviated discussion about my role and how to support with this particular case.
Excellent, thank you. And before we open up to a little bit of Q&A, I'm just going to go back to each of you because we've had a lot of questions coming up about how would one engage with each of your roles individually? What would be a referral process that they would need to get through, or do they need one to reach out to you? So Dr. Kitamara, if we could start with you first, how does one be able to come and access your services?
Yeah, so I'm reachable through either Baycrest or the team at the Peel Deference CMHA. So it's kind of works nicely. It's sort of an internal referral process. I think, fortunately, the team at the CMHA is great, and they get referred for patients who may not even need to see me. It may just be around support and planning, and then they'll connect with me if there are other issues. And otherwise, I think there's at least maybe one other geriatric psychiatrist, for example, in the whole Peel area or the Dufferin area. Anyhow, there used to be. So it's we are centralized more in the urban centers, and you're going to find people that aren't designated geriatric psychiatrists, but see a lot of seniors and are have that added lens. And also, worth noting, every long-term care facility, as you might know, has a psychiatrist connected, and obviously would have some comfort in treating older adults, although may or may not be a geriatric psychiatrist sort of formally.
Thank you so much. Candace, in terms of reaching out through the LIN, what's our
so there's
process?
14 home and community care organizations across the province. Thing that is important to know is that anyone can refer to home and community care. It does not need to be a physician referral. You can call and express the concerns, and it could be that it's for services, it could be for information and referral purposes. We have community intake that will support with that, as well as from the hospital. We also get our referrals through inpatient and emerge through our hospital partners. So physicians also do make referrals, and we have specific referral forms for them. And of course, our community partners also frequently refer patients to us when they identify risk or concern. And then we get the patient's consent to become involved. And that can be a bit of a challenge at times, of course, because a person, you're trying to speak to them over the phone. So sometimes there's creative ways of doing door knocks or drop-ins and working together with our partners and to see if we can make that connection so that we can help persons to understand the benefit or value of what we can bring.
Thank you so much. And Shauna, if you could let us know how one would be able to engage with you. And a few comments have come up even during COVID. How does that look right now? If you could help people see that as well and understand how that looks.
So unlike my colleagues, designated capacity assessors, we are all, I believe all of us are self-employed. So we are not covered by OHIP. And so typically the person who asks for the assessment is responsible for payment for that assessment. Now, obviously, there's a little bit of flexibility in that, but the referrals can come from anywhere. Similarly, to the Access Center, we don't have to have a doctor's referral. So my referrals come from the LHIN, they come from family members, they come from friends. The other big difference for me as a capacity assessor, I bridge that gap between the medical and legal. And so I don't need consent in the same way that my colleagues need consent in order to do treatment. So a capacity assessment will only be done if there's some reason to believe that that person is incapable of making their decisions. So we can't ask someone we believe in good faith to be incapable. We can't ask them to consent. That's ironic or something. So there's a loophole with capacity assessments that the only person who can actually refuse the capacity assessment is the client being assessed. And so there's a rights advice process. So capacity assessments require assent, not consent. And so we require the client not to refuse. And so that means we don't need substitute decision maker consent. We don't need doctors. We don't need anybody except the client to say, yes, I will talk to you. I understand that you're going to do this assessment, and I'm responsible to explain to them the potential outcomes and that they have the right to refuse. I have to explicitly verbatim tell them that they have the right to refuse. And if they don't refuse and they continue talking to me, then we can continue with the capacity assessment. During COVID, it's getting a little bit tighter. A lot of us are doing assessments remotely. A lot of us are doing assessments by video conference. It's a bit of a mishmash. Since COVID, I've been doing assessments for people across the province, simply because video has opened it up for somebody from London to call me when I live near Lindsay. And so there are fewer of us working, but there are assessors still working. So certainly you can get a list of designated capacity assessors online. If you go to the capacity assessment office or just even type in Google list of capacity assessors, it will bring up a list of all of the people in the province who are trained. And there's only, I think, 122 of us around the province. And so there's not huge numbers, but you should be able to locate someone to discuss the situation and help you out if you need that solution.
Excellent, wonderful, thank you so much. And Courtney, engaging with your team at CAMH.
Yeah, so my referrals are what we consider a direct referral process. So I get calls directly to myself. I get them again from community agencies, doctors' offices, the LHIN, et cetera. And it also comes through our central intake. So I know there have been questions about whether or not there's seniors at risk in other communities. Again, I would encourage individuals to check 211 in their area and just connect with what agencies that they are aware of to see whether or not it's something that's available and how to reach out to them as well.
Wonderful. Thank you. Thank you to everyone on our panel for this open and candid discussion. We are going to try and get through some of the questions that our attendees have posted. Hopefully we'll have a little bit of time, as I know we're up till 2:30. So we've got quite a few questions for Dr. Kitamara, beginning with, and Courtney's going to help me with some of the Q&A management as well, asking about carrying out capacity to manage finances under the Mental Health Act. Were you ever able to do this? Someone was asking.
Yeah,
Yes.
this. Oh, sorry, Shauna, do you want to go ahead? Okay.
Sorry, that's fine. Either one of us could.
Please.
Yes, there still is a mechanism if someone is in a facility that is designated as a healthcare facility. Psychiatry can assess them under Section 15. And please, Dr. Kitamara, you'll know more about that than I will. So I overjumped you.
No problem. Actually, I don't do inpatient work, so I'm a little bit removed. But I know that, yeah, there's actually, it's a requirement, as I understand, yeah, when somebody has that admission to make a decision. And often it's done in a very brief and probably sometimes inadequate way. And yeah, I would say it's a challenging area because I think even the inpatient psychiatrists are tasked to do it, but probably don't have certainly the training that Shauna would have. But I think are supposed to go through the same types of process to assess understanding and appreciation. And yeah, and
the Substitute Decisions Act reads, "You shall assess them." It's not ideal, but it does open the door, particularly if someone is not cooperating, because if they refuse an assessment in the community, sometimes the only possible way is to, if they're admitted, then maybe we can get an assessment done under mental health. And that might save going to court, but it's not the ideal situation.
Of course, definitely. Thank you. Courtney?
So our next question again is for Dr. Kitamara. The question is, it is less complex to reverse a finding of incapacity under the Mental Health Act than a finding of incapacity under the Substitute Decision Act. I'm wondering, what is your ratio of finding of incapacity under the Mental Health Act versus the Substitute Decision Making Act?
Yeah, and I'm not sure that I maybe fully appreciate the nuance, and maybe some of the others could help me. But you know, I guess when you're talking about a physician decision, it would be in pretty much all cases, except for those few ones around finances we're talking, and there's its own process. But treatment, assessing one's capacity to make treatment decisions is an ongoing thing, and certainly it can vary. A classic example of someone who might be psychotic presents to hospital is not capable, and in hospital there's certain forms under the Mental Health Act to notify the patient and to complete and give the opportunity to apply to the Consent and Capacity Board. But then with treatment, patients can become capable, right? And the actual process of assessing that is a straightforward clinical one, right? And I document in my notes accordingly. And I think there's slight variance in terms of how what if any forms need to be completed. In the outpatient world, it's almost always done in the course of my regular documentation, whether I'm finding someone capable or not, and if not, the process of going to the substitute decision maker and getting substitute consent. And kind of in doing so, also there is that process of assessing the substitute decision maker if they're capable, right? And we haven't talked too much about that, but that sometimes is questionable and needs testing as well too.
Excellent, thank you. We've got a question, quite a few people have said and kind of asked in different ways, talking about what if there's a situation where the person's capacity is questioned and they have a clause in their power of attorney that stipulates that they need to be found incapable with a formal assessment before the POA can take responsibility for their finances. Now, what happens if the person refuses to consent to having the capacity assessment and also refuses to pay for the cost of the assessment? Sean, I see you ready to dive in here and help us answer this.
Okay. Yes. So important to differentiate again between consent and assent. Okay, so social workers, OTs, people call me all the time saying the client is going to refuse the assessment. So my message to them is that it's a lot about how you pose the question, and it's a lot about exactly what it is that we're needing to gain here. We're needing to get Ascent to participate in talking to me about the things that I tell them specifically that I'm doing. So it's not, so I discourage, if someone's really resisting an assessment, I don't want the nurse, the doctor, the social worker, everybody telling them about, hey, Shauna's coming to see if you're capable, because you're immediately setting them up to say, I'm not talking to her. Like, why would I do that? Okay, so I need a foot in the door. I need a foot in the door, and then it's my responsibility, my obligation to explain to them the purpose of the assessment. So it's very point informed, very specific and explicit. I'm here for this. These are the potential outcomes. You have the right to refuse. And will they keep talking to me, or do they escort me to the door? Okay, I've only been escorted to the door once, because it really is about building that rapport and about talking to the people about, and they have the opportunity to prove, all these people that are saying they're incapable, they have the opportunity to prove them wrong, right? So that's often my foot in the door, is that my job is to decide whether you are capable and can make your own decisions, or if you're not capable and you can't. And the ones that are quite incapable are all going, I can. And you just, okay, well then prove it, and we'll get everybody off your back. Okay. As far as paying for it, I mean, yeah, that's a tricky one. If they have the means, I mean, their power of attorney cannot be activated without it. And so the next thing would be going into court, depending whether it's healthcare decisions or whether it's financial decisions. It would follow a slightly different path. For healthcare decisions, again, we don't need consent. And so sometimes I've had to tell people, you don't have to speak to me, but if you don't want to speak to me, then I will have to base my opinion of your understanding on what's in the chart. Right? So you don't need to talk to me if you don't want to, but I am going to offer my opinion of your capacity based on other stuff if I can't talk to you about it. So here's your opportunity to prove me wrong.
Excellent, thank you. And Candace, similar, if someone is refusing an assessment for going into long-term care, what would that look like? We've had a few questions around that.
That's actually similar to what Shauna just said, in the sense of we want people to participate. We will reapproach, we'll try everything we can to get patients to participate. And if they don't, we may have to proceed on the basis of the information that's available to us, the collateral. So that's very critical, is to have that collateral that's really going to substantiate the findings, because, you know, if you look through the collateral and it doesn't help support, then, you know, you just can't proceed, really. They're going to be found likely capable. But we don't, generally speaking, I have to be honest, to Shauna's point too, where she said, like, in once, it's in the art of the delivery, you're able to usually find a way to complete the assessment.
Thank you. And last question, just to end our time, even though I know we've got still so many to get to. Can a person have a translator? Maybe that be an ASL translator, a first language translator if English is not their first language, with them at a capacity assessment, and also for a geriatric assessment with you, Dr. Kitamara, if everyone could sort of answer that.
I can say we have an obligation to ensure that we are optimizing that person and their performance. So if they have, English is not their first language, we're bringing a translator.
Excellent, thank you.
Same
Shauna?
for me. Yeah, same thing. We're obligated.
Yeah, likewise. And I would say that there's often available and willing family members to serve that role, but there are some important advantages of having a professional translator if it's available where you work. It's amazing how some of the messaging can get sort of morphed a little bit if there's a family member who then has their own history and emotions and thoughts, right? And
Yes.
especially in sensitive areas, you know, in our world, asking about things like suicide, you know, for example, you'd be amazed how it actually, the question totally becomes nothing about suicide when you ask about it through the translator.
Very true.
Yeah. Thank you.
Excellent. Well, thank you. Thank you so much to everyone. Thank you to our wonderful distinguished panel today for their time, all their input into making this webinar such a success. I'm going to turn it over now to my colleague, Rayanne, to finish off the day for us. Thank you again to everybody.
Thank you, everyone. That was such a informed discussion. Always learn something new every time that we do these presentations. So I just want to bring highlights to a few sessions that we will be doing. We have a knowledge exchange day coming up on, just even following up on our discussion today about the legal response to elder abuse. So we will again have a panel of speakers, including a police officer and someone from the Office of the Public Guardian Trustee. So please, I encourage you to sign up. It is posted on our website, so you'll find some information there as well. And we do have a few more coming up, webinars in April, so stay tuned. If you're not on our mailing list, I encourage you to go to our website and sign up so you'll receive all the notices of our upcoming events that are happening. Another event that's happening in regards to the human rights of older persons, we've been doing a few sessions or series on this issue. So on March 30th, there's another event that's happening with the Ontario Longevity Centre, and you'll see all the partners there. So if you're interested, again, you can sign up for that webinar as well. Again, thank you to all our speakers. Again, here is some websites, so you might be able to find some of our speakers. Just as a reminder, the webinar will be posted on our website either later tonight or tomorrow. So you'll be able to access this recording as well as the PDF of the presentation for your own viewing after the session today. Just as a reminder, there will be a survey that'll pop up after the webinar. So if you take a couple minutes just to give us your feedback, we greatly appreciate that as well. And the contact information for myself and for Mary, if you'd like further information. I know there was some comments about organizing training. If you have any other further questions, you can reach out to us as well by email or phone. And I did put Mary, there shouldn't be a number sign there. I apologize. I'll fix that before I post it. We apologize for not getting to everybody's question today. We try our best to summarize the generality and themes. Again, if you have an individual situation that you wanted to reach out to for further information, please give us a call or email, and we'll try to provide the response or refer you to one of our keynote speakers today for follow-up referral. So thank you all again. And we do appreciate your time for participating today, and to our speakers.
Thank you, everyone. Have a good afternoon.